No problem. Morning, everybody. I think we should make a start because, as is typical when we join colleagues across the world, for some of our colleagues, this is a very awkward time to meet. So I want to keep us to time so that our colleagues in Canada and in Israel don't have too hard a time with our timing of today. So first of all, can I say certainly in Melbourne, Australia, good morning to everybody, and wherever you are in the world, a very warm welcome to you, beaming here from the Peter MacCallum Cancer Centre in Melbourne. My name is Professor Shelley Dolan, and I'm the Chief Executive Officer at Peter Mac. I've been here almost 4 years now, and it is my absolute pleasure to be hosting this morning's symposium in advance of World Cancer Day, which is, of course, tomorrow. So a very, very warm welcome to everybody attending, whether you are here in Parkville, whether you are tuning in from any of the Peter Mac campus across Victoria, whether you are tuning in from the rest of Australia or indeed from across the world. We are so delighted to be here with you and hosting you. The really important thing, and couldn't be more important with the theme of today's symposium, it is really important for me to acknowledge that wherever we meet in Australia, we meet on the lands of Australia's first people. And I pay my very, very deep respect to their enduring connection over 60,000 years to this beautiful country. And I pay my respects to the Wurundjeri people of the Kulin Nation and to elders past, present, and emerging, and anyone from First Nations people gathered here today. And we are very lucky indeed that we are going to hear from some of our First Nation people. I also want to give a thank you to all of our speakers who have agreed to share their amazing wealth of experience today. I want to extend a particular welcome to our international guests, Dr. Mary Gospodarovich. I'm sorry, Mary, if I pronounced that badly, from Princess Margaret Cancer Centre in Toronto, Canada, and Dr. Damien Urban from Sheba Medical Centre in Tel Aviv, Israel. More about that in a minute, but we have all been looking forward to hearing from you. We are absolutely delighted to be able to share this symposium today with colleagues from Sheba and Princess Margaret. And I have had a long relationship with Princess Margaret. Mary may not know that. Sancha says I can call you Mary G. I hope that's all right. But when I was a nurse consultant working at the Royal Marsden, I was very lucky to be involved, as Sancha has been, as Andy Dimmock has been, with the International Society of Nurses in Cancer Care. And at that time, I think she was called our president, was Margaret Fitch. And we together went to Princess Margaret several times. And it is the most wonderful institution. And as many people now know, we are now formal partners. And that is absolutely wonderful. My relationship with Sheba and Israel is also very long. This may be just because of my advancing years or something. But I had the huge honor hundreds of years ago to be the lead for the European Blood and Marrow Transplant Society, and particularly the nursing part. And I remember well, as a young nurse, I think a clinical nurse specialist then, the nurses from Israel ringing me from Tel Aviv saying, can we be part of the European Society? And having listened to them and their excellence in teaching and research and care, I said, of course, why wouldn't we want you to be with us? And so they became a part of EBMT. Oh, that must be 30 years ago, and they are still a really wonderful part. And so I got to visit Beersheba several times. But more recently, it has been my huge privilege and delight to become part of the Futures of Health that Bathsheba has got up, and I'm really delighted to be part of that summit and part of that body of 50, I think it's 50 CEOs from across the world looking at best practice in healthcare. And so I was in Israel just a few months ago with wonderful colleagues. Sheba is one of the top 10 hospitals in the world, and it is an absolute leader in many aspects of medical research and care, but very much cancer care. And Princess Margaret Centre is one of the largest comprehensive cancer treatment facilities in the world. They both embrace technology in how we work with cancer, and they are both interested and passionate about collaboration and working with the international community to improve best practice. So it couldn't be more fitting on World Cancer Day, excuse me, that we look out. It's such an opportunity for us to look out and learn and work with others. And so tomorrow on World Cancer Day, but today for us, we bring the global cancer community together and we reflect on that global impact of cancer and look at our progress towards improving the whole of the cancer journey. Really importantly, this year's World Cancer Day theme is closing the care gap. And this is very much about recognizing the inequities that many people still face in accessing cancer care. It's incredibly important. One of the things that I learned when I was preparing for my interview to come to Australia was Australia has some of the best outcomes from cancer in the world, but not all Australians can access that care and have those outcomes. And that's why we're here today. Because across the world, as you know, there are people that can access absolutely wonderful research-driven care, and there are people who still can't. And that is untenable, and that is our mission to ensure that we improve that. And that's why we're here today. As the only public comprehensive cancer centre in Australia, we take this very seriously. And I'm delighted that we have speakers here today from every discipline who will help us learn more about what we must do. Our speakers today include addressing health inequities for Aboriginal and Torres Strait Islander people, people living in rural and regional areas, and those more vulnerable members of the community. What you will hear today is just a hint of the many projects and initiatives underway here at Peter Mac. It's very important for us because the statistics are that closing the care gap in Australia means improving outcomes for Aboriginal and Torres Strait Islander people who have a 54% 5-year survival, compared to over 80% in the broader population. And they are 3 times more likely to die from cancer than other Victorians. Those statistics are just not acceptable, are they? So it means that we must focus. We also need to improve our knowledge about the needs and access needs of all people, including LGBTQIA+ people. Every part of our society has needs that we need to embrace, and we need to do better at that. And we are going to learn more today about how we can improve that awareness, particularly in screening diagnosis. It's also really important in a country as large as Australia, and of course, this would be also similar for Canada, that regional communities whose inhabitants are 44% more likely to be diagnosed with melanoma than those living in major cities, but 10 times more likely to die from cancer. So with cancer touching the lives of so many people globally, it is essential that we come together, that we pour together the brain's trust across the world and identify and find new solutions around prevention, identification, societal inequities, and that we come together as we are today to learn. With that in mind, I am really happy and I'm sure you are, because we're going to get on to the meat now, to introduce our first speaker, Dr. Marlies Alexander. Dr. Alexander is the Deputy Director of Pharmacy here at Peter Mac, and she is a research fellow in the Sir Peter MacCallum Department of Oncology at the University of Melbourne. She holds a Bachelor of Pharmacy, a Master of Public Health, and a Certificate in Data Science. Her PhD focused on cancer-associated thrombosis, thoracic cancers, and real-world data. Her current research efforts focus on real-world data and personalized therapeutics for the treatment and supportive care of cancer and outcomes for people with thoracic cancers. Today, excuse me, Dr. Alexander will speak on Peter Mac's pharmacy initiatives to use pharmacogenomics to tailor treatment and the expansion of these services to our rural and regional communities. Let's give a warm welcome to Marlies.
Thank you, Shelley, for that very kind introduction. And it's an absolute pleasure to be here presenting today to share some of the initiatives of the Peter Mac Pharmacy Department in terms of our precision medicine programs. Now, sorry if I can get into the slides. So my presentation today is going to talk through a number of different programs led by the Peter Mac Pharmacy Department around precision medicine initiatives. Before I get into the detail, I wanted to give a high-level overview of some of our programs that aim to provide personalised approaches to medicines management. Now, the first example uses biomarkers to achieve this, and the second two examples use genomics. And I'm going to get into the specific programs on the coming slides. But what's important to note here is that a third and up to 50% of our participants have come from regional centres. And we achieved this through our regional network collaboration that you can see on the slide there, and using the tally trial model. Now, what's important is that that primary site is us at Peter Mac, and we work collaboratively to deliver shared care to our regional and rural sites. And so that means that our regional patients can attend their local healthcare service, but they can access the trials, the medicines, and the testing platforms that come through our specialist services here at Peter Mac. The focus of this presentation is now going to go largely into the genomics programs. So I wanted to start by covering some of the terminology. So pharmacogenomics is about the selection and dosing of medicines according to gene profiles. And if we think about traditional dosing of medicines, we give the same dose of medication to everyone. And for most people, this works effectively. But for some people, the dose is too high and they can experience side effects. Sometimes these can be very severe and even life-threatening. Yet for others, the dose is too low and the medicine isn't effective. So when we take the pharmacogenomic approach, we have a look at your gene profile and then we tailor what dose of medicine we give you. It might be slightly higher or slightly lower to that standard traditional dose. When we look at the application of pharmacogenomics in cancer, there's significant potential to impact the optimization of medicines management. The classes of medicines that I've listed on the slide here are those that have genomic implications, but also those that are commonly prescribed during cancer care. Now, these can be cancer-directed therapies, or they might be medications that are used as part of supportive care. And I've highlighted two of the cancer medicines there, so the fluoropyrimidines and irinotecan chemotherapies. Now, these have probably the strongest evidence base for pharmacogenomics, and this is where our Peter Mac pharmacogenomic story started. And we did this under what we called the Pacific trial, and I've labelled it here reactive genomics. And that's because we ran this trial in this clinical service model where it's the prescription of these medications that trigger the genomic testing to then understand how we can optimise the dosing. As we move forward, we're moving into what we call the precision genomics space, and we're looking to instead test for a much broader panel of genes that impact a broader panel of medicines. So in fact, all of those medicines classes I've listed on the slide. And I've termed this preemptive genomics. And what we're thinking is that we're going to shift the testing forward in the landscape. So we're going to test people as part of their diagnostic workup. And then as clinicians prescribe these medications over time, they've got this genomic information ahead of time and can optimize their prescribing accordingly. Now, on the right-hand side of the slide, I've got some pretty detailed graphics, which I don't need you to digest in full, but I wanted to give an example of how pharmacogenomics works on the specific case studies of a couple of those cancer medicines that I described. So starting at the top of the screen with our fluoropyrimidines, which are a class of chemotherapy drugs commonly used mostly to treat solid cancers. We know around a third of patients who receive these drugs have really severe toxicities, even life-threatening. We know that the majority of this drug is broken down by one particular enzyme called the DPD enzyme. And if you have a deficiency in the gene that codes for that enzyme, so the DPYD gene, you're at risk of severe toxicity or death if you're exposed to even just the standard dose range. And then if we take the similar example with irinotecan down the bottom, so if we follow the schematic through, irinotecan is actually converted to an active form in the body. And then within the liver, it's deactivated. And this happens by the UGT enzymes. And again, that's coded by a gene, the UGT1A1 gene. And if you're deficient, which around 10% of people are, you're at high risk of severe toxicities. And so the idea is screening up front, we can identify and tailor the dosing of our medications. Because pharmacogenomics has the potential to impact a wide range of medicines, touching a wide range of specialties, the approach we're taking at Peter Mac is to assess a model of care where pharmacy is the central link between the pharmacogenomic testing and working closely with our expert prescribing specialties. So this is really a multidisciplinary cross-collaboration. This slide's a bit busy, but I'm going to attempt to walk you through the pharmacogenomics journey that we've had here at Peter Mac. And at the outset, I'd like to acknowledge that this has largely been led by our Director of Pharmacy, Mr. Senthil Lingaratnam, who really drove the establishment of our genomics program and remains a key part of the research and clinical service team to date. So we start on the left with our Pacific PGX, and this is our reflex testing for those two genes that I described to you earlier. So we start with a prescription of a medication, and then that triggers the genomic testing, and we implement dose changes based on that. On the subsequent slides, I'll highlight some of the key results, but needless to say, it was so successful, this has now been approved and is standard of care here at Peter Mac and at our regional partners at Bendigo. We're moving into the precision PGX phase now, where we're moving to that broad panel testing that I described. So we've now got multiple targets that we're looking for, and we're shifting to that preemptive phase. So we're testing earlier in the journey so that the results are available across the journey. In phase one, this is where we are now. We're still limiting our medicines interventions to those couple of medicines that are approved for standard of care. But what we're going to do is, by conducting the panel genome testing, we're going to learn and we're going to optimize our interventions that in phase two, we can then implement across the board. And so phase two brings everything together. We have the preemptive testing, we have a broad panel of genes and multiple targets, and we're now prescribing interventions across a wide range of medicines. And that brings all of our programs together. So we're hoping to reach phase two in the next 2 years. Coming to the key results of the Pacific PGX trial. So this was our first experience of those two targeted gene tests for those two chemotherapy drugs that I talked you through earlier. So we had 27% of our patients accrued from regional sites. The trial was open at Peter Mac, Bendigo, Border and Swan Hill. And we had outreach through collaborators and shared care models where patients would attend their local services, but see our specialist pharmacogenomics service through our virtual clinic. And what we established was that it was a feasible model of care. The turnaround time for testing was between 5 and 7 days for the two genes, which really fit into the normal clinical model of care for these patients. They weren't waiting for tests before they started their care. And importantly, we validated that our virtual clinic and our shared care model was acceptable for patients and clinicians. And we did this at scale too, and the numbers in the first table there, we had over 450 patients undergoing testing for DPYD and 50 for irinotecan, and this was just our first 12-month experience. And a little sneak peek in the data at the bottom, so our PhD candidate, Sarah Lewis, who has been leading this work, this is 17 patients who had genomic profiles that would predict for very severe toxicity or even death if they were exposed to standard doses of these agents. And of the 17 patients, only one patient had a high-grade toxicity. The rest of the patients were managed safely on care. And that's a really great outcome for the trial and more importantly for these individual patients. Moving on to the precision trial. So this is our next phase. This is where we are at the moment. We're embarking on a multi-centre study. We're opening here first at Peter Mac and reaching out to our regional partners in the expansion phase. And we're looking at over 35% accrual from our regional centres. So again, embracing that same model of care. And as a reminder, the precision is our broader panel testing. So we're testing for a wide range of genes impacting a wide range of medicines, and we're moving to the preemptive setting, so at the start of the cancer journey. This will occur in two phases. We have our first observational phase, where we're learning how to use the genomic data and optimize our interventions. And then we have the intervention phase, where we can assess if this broad range of interventions across all of our medicine classes actually improves outcomes for our patients. And a key component of this will be assessing the acceptability, feasibility, and of course, cost effectiveness. Now, this being in the infancy of its program, I don't have that data to share, but what I can share with you is some of the cost data from the Target TP trial. Now, this was one of the trials I showed on the first slide. It's a biomarker trial, so it uses biomarkers to personalise treatment rather than genomics, but it has exactly the same structure. The regional metro hub spoke model, where patients go to regional sites but get care through the shared services. And we ran an analysis from the patient perspective, and this is the cost to the patient: time, travel, productivity loss, if they had to come to Peter Mac for each of their trial visits and assessments rather than their local centre. And across all 5 centres, there was a $1.7 million saving for patients by running it in this way. And this is one trial over a short period of time. You can imagine the scale if this was extended to multiple trials and clinical service models. So my final parting slide, there's many benefits to regional rural partnerships, both for the regional sites and for the metro sites. We can improve access for regional patients, reduce barriers to care, improve the generalisation of our trials. Our trials no longer need to be Peter Mac centric, and we get a representative model of people in our trials. We start designing trials and clinical service models that can actually be implemented across a range of services with different resource and needs. So automatically our programs are scalable at the end of our test periods. We're building collaborations at networks, and I can't speak enough to the mentoring and the wonderful relationships that I've formed with our regional partners. So I hope that's given you a glimpse into what some of the work from our pharmacy department, and it's been an absolute pleasure to share that with you today.
Thank you so much, Marlies, and I don't think you could have illustrated so beautifully why it's so important, the regional and rural reach and the personalisation of treatment. Thank you so much. It's now my great pleasure to introduce Dr. Damien Urban, and I think it's very, very late at night or early in the morning. Dr. Urban is head of the Inpatient Oncology Service and Director of the Rapid Cancer Diagnostics Unit at Sheba Medical Centre. Dr. Urban completed his medical training at Monash University here in Melbourne, and he has since completed his specialisation in oncology at the Sheba Medical Centre. He is well published and has participated in clinical research and workshops at all of the major cancer conferences. In 2014, Dr. Urban was granted a NanoString Pan Cancer Award, highlighting his success in the field of mutations and immune response in head and neck cancer. It is really exciting to welcome Dr. Urban to speak today, reflecting the close relationship between our two organisations, which was formalised in May 2022. So without any further ado, and to make sure that Dr. Urban stays awake, please can I give a warm welcome and thank you to Dr. Urban.
Thank you very much. I hope you're all hearing me, but really a great honour to be here tonight or morning. Thank you very, very much for the invitation. One small suggestion, Shelley, I mean, next year, we could actually improve things and potentially, instead of sending me a Zoom link, I'd be happy if you would send me a ticket to come and visit my friends, and their colleagues in Peter Mac, where I worked for a number of years, and my parents and family in Australia. I'm going to talk about a topic that's really dear to my heart, and that's, as a clinician, we often see patients that unfortunately deteriorate very quickly, and quite quickly after their diagnosis, they actually pass away and die. And this early mortality in cancer is something that I've been looking at in the last few years. And the question is, can we improve outcomes in these patients who are usually excluded from clinical trials? We know that clinical trials usually treat patients that are, they are sick with cancer, but they're actually quite well, they're functioning, and they've got generally an expected life expectancy of, a certain, at least a few months. And the question is, there's a number of patients that actually aren't able to be included on clinical trials, and the question is, can we improve their outcome? These are my disclosures. Just sort of as a background, I mainly treat lung cancer today, and 20 years ago, this is how we treated metastatic non-small cell lung cancer. Basically, we treated all the patients the same way, and unfortunately, when we look at what we call as a median survival, so 50% of patients unfortunately do not make it to that date, and 50% do. So the median survival of metastatic non-small cell lung cancer about 20 years ago was about 7 to 8 months. And very few of these patients survived over 2 years. And these are patients that were enrolled in clinical trials. And what we've realized over the last 20 years is that non-small cell lung cancer is not one disease, and it's actually multiple different types of cancers with different genetic and other factors that are both related to the cause of the cancer and also how the cancer behaves and how they respond to treatments. And today we're actually able to identify many different subtypes of lung cancer, and we can treat them very differently. And I won't go through too much data, but we can actually recognise some patients, and some of these patients have actually quite, good outcomes. So some of our patients with metastatic non-small cell lung cancer, who express what we call PD-L1, above 50%, which is actually about 30% of our patients. So 30% of them will survive over 5 years. And just so people understand, some of these patients will get treatment for 2 years and then we'll stop treatment, and we don't need any more treatment, and they're still surviving, many years after that. And it's about, 50% of our patients of these 30% will actually survive, 30% of these patients will survive over 5 years. Another subgroup are these some patients with mutations in the cancers, which will have biological treatments, which are usually tablets that they take at home. And we look at, let's say, EGFR mutations, it's about another 10 to 15% of our metastatic non-small cell lung cancer patients. And here also about 50% of those patients will be surviving over 3 years and beyond. Another group, our positive patients, often young patients. Also here, we've got a median survival, up to even 8 years. So not 50% of patients are surviving beyond 8 years. And that's just totally different story to what we had 20 years ago. Unfortunately, these data are all data from clinical trial patients. And as I mentioned, these are the healthiest of our cancer patients. The question is, what happens in the real world? So we've been looking at this. It's a manuscript we're actually in the process of publishing. This is data from America, looking at what's the 2-month mortality rate of metastatic cancer. And the data is actually mind-boggling. It's mind-blowing. You look at, let's say, lung cancer. So in the real world, about 25% of metastatic lung cancer patients will die within 2 months. Look at pancreatic cancer, about 30% of patients will die within 2 months. And liver cancer, that's up to 35% of patients are dying within 2 months. And we do see also some differences between different ethnic groups and races, etc. What's also, we've shown over the last 20 years significant improvement in the long-term survival. But if we look at the 2-month mortality rate, it actually has hardly changed in the last 20 years. And that's quite disappointing. Then I saw this data. I wondered, is that something that's specific to America, or is that something that's a worldwide phenomenon? So I went to the Israeli Cancer Registry and asked them, what is the 2-month, that's meant to be mortality, so not survival, 2-month mortality of lung cancer patients with metastatic disease. And in Israel, it's 27%. So there we see very similar to the data in America. And then 2 or 3 years ago, I saw this presentation at one of the World Lung Cancer conferences, looking at the impact of COVID-19 in the diagnosis and prognosis of lung cancer. And we see over, the red line is during COVID and the blue line is before COVID. So we see that the number of diagnoses are less during COVID, and obviously that reflects patients not presenting to medical care during the COVID period because of the fear of contracting COVID. Look at the 30-day mortality over here. 49% of patients died within 30 days after they got diagnosed with lung cancer. And if we look at the data before COVID, and this is the European study in France and Spain, we see that 25% of them die within 30 days. So once again, it's something that's across the board, Europe, America, Israel, etc. There's another American study looking at, patients, over, 300,000 patients, and 13% of these patients died within 30 days of having a pathologically confirmed metastatic diagnosis. Now, these are patients that the physician considered them well enough to have a biopsy, but unfortunately still 13% of them died within 30 days, and 71% of them received no systemic treatment. And the question is, why is this happening? And there are multi-factors. I think it's related also to the biology of the disease sometimes, but it's also related to the complex process of diagnosis. When these symptoms, when does the patient recognize these symptoms are suspicious for a serious disease like cancer? When does the family physician, realize that these symptoms are suspicious? They get referred to a specialist. How long does that take? Referred to the hospital. And then we know there's a whole range of tests that a patient has to get through until he gets to the oncologist and until he starts treatment. And that's including biopsies, waiting for results of the pathology report, getting other imaging things like PET-CT, MRIs, etc. This diagnostic interval, and we divide it sort of into two main areas: the primary care interval, which is when a patient presents to the primary care physician, family doctor, until they realise there's a suspicion of cancer, and then the secondary care interval, where there's a referral to further workup until a diagnosis. So we started a clinic about 4.5 years ago, run by oncologists, where patients with a pre-test cognitive cancer, usually metastatic or locally advanced, that is greater than 90%. And we've seen over 2,000 patients in this 4-year period. We see the patients within 1 or 2 days of referral. And a quarter of those patients have lung cancer. There's just a few of the diagnoses that we've seen, and this is just from the first 330 patients. So we see there's quite a lot of lung cancer patients. We had some pancreatic cancer patients, some hematological malignancies, and we had about 10% of patients that actually didn't have cancer in our clinic. If we look at the lung cancer patients, and this is data from before, up to nearly a couple of years ago, where we had about 22% of our patients with lung cancer. And of these 337 patients with lung cancer, 45 of them died within 2 months. That's about 12%. It seems a bit better than the 27% that we've seen in Israel generally. But it's still a little bit disappointing. And of 34 of them that had non-small cell lung cancer, we actually identified a number of patients that had what we call driver mutations that are in the cancer, that we have treatments that, we can give them tablets, and often within a few days, a week or two, they really improve significantly. And these patients potentially could have lived, for a number of years with a very good quality of life. Unfortunately, these patients that died, some of these results actually came back after they had passed away. So I don't want to extend too long, but another study in Sweden looking at how long does it take for a patient reporting symptoms until a diagnosis. And in this Swedish study, we're talking about about 110 days. And another study showed that from symptom to start of treatment was nearly half a year. It was 189 days. It's about half a year to start treatment. And I just want to bring two case presentations, patients of mine that I've treated, just to sort of highlight, what can happen. This is a 60-year-old patient with no medical history, a never smoker. He's had he's actually on a holiday in Thailand. He had 2 weeks of headache and confusion, he had polyuria polydipsis. He was very thirsty, drinking a lot and passing urine. And he presented to the emergency department in Thailand, where a CT brain showed multiple brain lesions. He quickly hopped on the plane to Israel, they did a brain MRI, which showed innumerable brain metastases, and a CT scan which showed a lung lesion and lymph nodes in his mediastinum. A few days later, he was referred to our rapid cancer diagnostic unit. And unfortunately, this was a time where there were many public holidays, in those couple of weeks. And so we only could schedule a biopsy for about 2 weeks later. And what we did then was we discussed with the patient what we call a blood-based liquid biopsy, where they take a blood test and they send it off. Unfortunately, it was commercial, so the patient would have to pay for it. And a few days later, and then they can detect the mutations in the blood. After a few days, the patient came back and said they actually had the private health insurance that can cover this test. And so we did the blood test, and 2 days later, he received a result of an EGFR mutation. And that mutation is very treatable. And we did the biopsy on the 15th of October. The 16th of October, we already got the blood result. We gave him a prescription for the tablet, the anti-cancer tablet. A few days later, we still did a biopsy and we got a result of the biopsy, but he already started treatment. And we see here, this is a brain MRI. We see one of the brain metastases here, another couple of these small ones. After a couple of weeks of treatment, significantly decreasing in size, and he's improving clinically significantly. Now, if we would have waited for the results of the mutation on the biopsy, that actually came back a month later. I'm not sure if he would have survived that month if we wouldn't have done that blood test. So that's just one way of speeding up the diagnostic process. And the second case is a 66-year-old, a heavy smoker, presented with a cough. On the chest X-ray, it looked like potentially pneumonia, had antibiotics that didn't improve. And then he did a CT scan, which I won't show you the CT scan, I'm going to show one slide here, which we see here, a lesion in the left lower lobe of the lung. And once again, so he went through a bronchoscopy. It took a couple of weeks to get a bronchoscopy. He had quite a little bit of a rare type of lung cancer, carcinosarcoma, which was diagnosed. He had also a pancreatic lesion. They did a biopsy of the pancreatic lesion, which didn't show cancer, but then they had to repeat that test, and then it did show cancer. So he had metastatic disease. He had to do an MRI scan and a PET scan, and all of these tests took time. We're talking about, 3 or 4 months with this diagnostic process. And by the time he presented to me, he was bedridden. He had lost 12 kilograms. He'd actually been in another hospital, and the other hospital recommended that he get best supportive care, hospice care. And then they actually came to our hospital, and he was admitted to the internal medical ward, and they asked me to review the patient. And actually, I had a long discussion, end-of-life discussion with the family. Actually, the patient really wasn't able to be actively involved in the discussion. His situation didn't really allow him to do that. And the family really wanted me to treat the patient, and I recommended them just to go to have really hospice care, exactly like the other hospital. And they really begged me to give him treatment. And being at the head of the inpatient ward, I have to use our resources carefully. And I didn't want this patient to stay in our ward for too long. And either I wanted him to go to a hospice or to have home hospice. And so I told the family that I'm willing to give him treatment on condition that they either take him to home hospice or they take him to an inpatient hospice care. And he actually, on the 23rd of August, he got treatment with a very, very low dose of chemotherapy and immunotherapy. And he was discharged with home hospice. And this is his X-ray a few days before he got treatment. And actually, 2 months later, I was looking through my clinic list, and there was a name of a patient that I actually didn't remember who he was. And I looked in the file. I remembered, that was that patient. I had a discussion with the family. I couldn't believe that he was on the list. And I actually thought maybe the family are coming just to have closure. And I called them into my room, and the patient actually walked in on his legs. I did a CT, chest X-ray on that day, and we see that his lung has totally re-expanded. And this patient is actually had another CT scan, which showed a significant improvement in his cancer. And he finished 2 years of treatment about 1.5 years ago. At the moment, he has no evidence of disease, fully functional. Now, this patient could have easily died within, within that, few months that it took them to, took Israel to work him up. I guess sometimes our treatments are very, very successful, and we don't always know which treatments are the right patients to treat. And I think many causes of potential early mortality, and I think today, it's an aggressive disease that probably no matter what we do, we won't be able to help. But part of it's related to delay in presentation or delay in workup, and things that can improve that are screening, education, both the public and the primary healthcare providers, also the accessibility to healthcare. Patients who live far further away or don't get access to that can definitely delay the diagnosis of lung cancer. Also recognising symptoms of cancer, and once again, the time to diagnosis. And I think, something else is access to treatment. So it's related to the time to diagnosis, but also access to treatment to know which patients we should be treating, how we should be treating, also know when not to treat patients and when we're really not using our resources well. So by us starting this rapid diagnostic cancer clinic, we've actually been able to, I think, improve certain outcomes with patients. And it's something that, we're hoping actually other hospitals are starting to do that in Israel as well. So thank you very much for that.
Thank you very much indeed, Dr. Urban. I hope you can hear me. I have noted that you want a plane ticket next time, and I've noted that down, and it would be absolutely wonderful to welcome you here in person. But thank you so much for a presentation this morning that I think has really moved, and you could hear a sharp intake of breath as everybody looked at that chest x-ray. So thank you for everything you're doing there in Israel, but also thank you for being with us today, and for, I know we'll be collaborating and meeting each other in the future. Thank you very much.
Thank you very much.
And now please go to sleep. Now, I think it's about 1 o'clock in the morning there. Now, it's my huge pleasure next to introduce Andrea Casey. Andrea is one of our Peter Mac Aboriginal Project Support Officers, and Andrea will speak to us about the hugely important work being done by herself and Jay Hammond across Peter Mac. One of the most important things for me coming to Australia was to sensitively learn about Australia's First People. And I would say that Jay and Andrea together have taken me on that journey. I still have much to learn, and therefore I'm absolutely delighted that we're going to hear from Andrea this morning. So let's give Andrea a very, very warm welcome. Oh, sorry.
Haven't done this for a while. Everything's been via Zoom. Put my little glasses on. While we're asking for plane tickets, I'd really like to get to Canada. So if we can collaborate with Canada, that would be amazing. So before I go any further, I'd like to acknowledge the traditional owners of the land that I'm on today, the Wurundjeri Woiwurrung people of the Kulin Nation. I'd like also to acknowledge their culture and connection to the land for tens of thousands of years. I also pay my respects to their elders past and present, and to any First Nations people attending today. Now, I've never used one of these clicky things, so let's hope that it works. Did it work? No, not yet. Oh, okay, cool. Okay, so I will tell you a little about Peter Mac's Aboriginal team, Aboriginal health team. So there are Aboriginal hospital liaison officers, mostly Jay over here in the lovely green, there she is, giving a wave. She is a full-time Aboriginal Hospital Liaison Officer, and I fill in for her, and I do Wednesdays as well, because once I got here and realised how amazing her job was, I wanted to jump in on that one. So you might ask what an Aboriginal Hospital Liaison Officer does, especially people who are tuning in from overseas perhaps. So in brief, AHLOs support patients and ensure culturally safe care. We determine individual needs to ensure the best patient-centred care, arrange transport, accommodation, appointments, all of those little details, sometimes big details. Liaise with both internal and external services, including Aboriginal community-controlled organisations, patient navigators here at Peter Mac, and clinicians and anyone else who's involved in the patient's care. We can attend appointments with the patients and their families if they want us to. Sometimes they really want that support. Other times it's like, no, we're fine. And we advocate for patients. So we might go along to an MDM and put our 2 cents worth in, with inflation, 20 cents worth in. So yeah, there's lots that happens, and I'm learning a lot from Jay. She's pretty amazing at it. We're lucky to have her. And my other role is Aboriginal Support Project Officer. And the main work that I do in that role is the implementation of Peter Mac's Innovate Reconciliation Action Plan, or RAP, with the aim of providing culturally safe and supportive service to Aboriginal and Torres Strait Islander communities while promoting self-determination and reconciliation. Now, you might wonder what a RAP is. Not everyone knows. So Reconciliation Australia says that since 2006, Reconciliation Action Plans, or RAPs, have enabled organisations to sustainably and strategically take meaningful action to advance reconciliation. Based around the core pillars of relationships, respect and opportunities, RAPs provide tangible and substantive benefits for Aboriginal and Torres Strait Islander peoples, increasing economic equity and supporting First Nations self-determination. And that's really important, and our commitment to that is really good. So, you know, we're doing great stuff, I think. Peter Mac's Innovate RAP contains over 70 actions and deliverables. The one that we're working on at the moment runs for 2 years. It expires in October this year, so I will actually be registering our new one and starting to work on that. So fun just never ends. The actions and deliverables cover such areas as procurement, and we've had a big win in that department. We have awarded a new uniform contract, corporate uniform contract, to an Aboriginal business, which is pretty incredible. Other areas that are covered in the RAP are people and culture, making sure that we're offering employment opportunities to First Nations people and making the whole application and employment process more culturally safe and appropriate. We offer staff training. We're establishing and maintaining mutually beneficial relationships with First Nations organisations. And one of those is the Victorian Aboriginal Health Service, where we are hoping that we can get some clinics run from, so that people can go to the clinic where they already feel safe and meet our staff there and have some of their initial appointments there. So it's not as scary. And then when they come into Peter Mac, they already know people, which is pretty amazing. And then the really fun stuff is hosting events for NAIDOC Week and National Reconciliation Week, which allows us an opportunity to show off our culture and our achievements and just have some fun. Okay, so, oops, I'm going to go back. Did it go back? No, it did not go back. Here we go. So how does Peter Mac's RAP work towards closing the gaps in healthcare? The RAP and the projects which come out of it are aimed at improving the care and overall experience of First Nations patients and community. An important part of this is working on cultural safety and cultural awareness in the whole organisation. So we offer our training to everyone, and there are modules in our onboarding that everyone is encouraged to do. And during that training, the issues around why Aboriginal and Torres Strait Islander people might not necessarily feel comfortable coming to the hospital are discussed, and there are some simple ways that people can make sure that they're offering a more culturally safe space, really. We host Asking the Question training. We have an amazing facilitator for that, and it provides information to staff on why we need to ask, do you identify as being of Aboriginal or Torres Strait Islander origin? And then also how to answer when people say, well, why do you want to know that? And I think that it's starting to make a bit of a difference, which is incredible. And I've already mentioned the outreach clinics that we want to have at VARS, so that's pretty cool. So let's get on to one of my projects that I've been working on along with Jay. So fail to attend appointments, which is really important. We looked at some of the data and realised that there were a lot of people who weren't coming to their appointments, and some of them, sometimes it was the same person not coming over and over again. So we needed to find out why. So I ran a survey with some patients to find out why, and also just through Jay and I talking to patients, we sort of figured out reasons, and we already knew some of them, didn't we, Jay? So often things like transport, accommodation, family or community commitments, or not understanding why you actually need to attend an appointment can be some of the barriers. Now, I know that I actually had cancer. Whoops, I'm 10 years free, yay. But I know that when I got the all clear and then I had to have appointments still just for checkups and whatever, sometimes I would be like, yeah, no, I don't want to go. I've been to the hospital enough. Luckily, I had a wonderful breast care nurse who followed up and said, hey, why weren't you here? But that's what we do, and we will call patients and say, hey, do you realise why you should have come to that appointment? We can help you to get here. We can do all sorts of things to try and get you to your appointment. And I think it's making a difference. So one example of addressing the barriers that we've come across recently is we had a family, a very large extended family, who needed to come from somewhere regionally that was about a 6-hour drive from Melbourne. So, that's quite a big deal. It was a group of 8 or 9 people, so that was a challenge as well. But we wanted to make sure that they could all get here as the patient was receiving some fairly confronting news. So we did the best that we could to get accommodation for the family. And that can be tricky because really we can only provide accommodation for 2 people. That's just how it goes. But through liaising and the family liaising with other Aboriginal community controlled organisations, there was funding given and the other accommodation was paid for, which meant they could all come. But then the days of the appointments, there were other challenges around being at the hospital itself, because generally you can't have so many people with you when you go to see a clinician. So we organised, or Jay rather, organised to have 2 rooms in the clinic available to the family, and half of the family were in one room, half were in the room next door on telehealth, and I was in the room with the patient and half of the family. It worked really well. Everyone was happy about that. And I think it made a real difference. So there was also something else that was really important during those appointments, because there were several all in a row, was giving time for the family to talk about what was happening and to ask questions along the way. And then another thing that we do, which helps with the fail to attend appointments as well, is promoting telehealth. And that's where patients who finished their treatment, or that they might still be having treatment, but it's just a tablet at home or something, they don't want to come in, if we find out that it's simply that they didn't want to come in, not that they don't want to engage with us anymore, we can make sure that they know about telehealth. So, you know, you can be quite over attending appointments, especially if you've come in every day for umpteen months. And then we do have an example of a patient who comes from just about an hour out of Melbourne, but even so, that's a big deal. If you're feeling unwell and you've been coming in all the time, this patient just doesn't want to come into the hospital, and that's okay. Of course, there are times where she has to, because she needs to have scans or be checked physically. So we advocate now for any appointments that can possibly happen via telehealth to happen that way. But another thing that we do too is make sure that if that patient needs to see several different people, we try to get all of the appointments to happen on the same day if she has to come in, which makes a really big difference to her. So I think that is about it for me. Thank you.
Andrea and Jay, thank you both so much. We are really lucky to have you both here at Peter Mac, and it is evident the real important difference you make, and we just need to do more and more of this across Peter Mac, Victoria and Australia, don't we? So thank you very much indeed. We are now really fortunate to hear from Professor Mary Gospodarovich. Mary G, and I hope you'll forgive me for calling you that, is Professor of Radiation Oncology from the University of Toronto and Princess Margaret Centre University Health Network. Mary G is a consultant radiation oncologist, past chair of radiation oncology, and past medical director at Princess Margaret Cancer Centre. She has participated in countless high-profile initiatives, including the Harvard-led Global Task Force on Cancer Care and Control, the Lancet Commission on Global Access to Pain Control and PAL Care, and the Lancet Oncology Global Access to Radiotherapy Commission. Her research interests include clinical trials, evaluating radiotherapy in lymphoma and gastrointestinal cancers, image-guided precision radiotherapy, and cancer survivorship. In May 2015, Mary G was awarded the Order of Canada for her contributions to improved cancer radiotherapy and for her leadership in advancing cancer care around the world. We are so delighted that you are here with us. A very, very warm welcome. Thank you for joining us.
Thank you very much, Shelley. It's a pleasure, and it's a pleasure to be in Melbourne today, even though virtually. Toronto is actually awaiting being enveloped in the polar vortex tonight. It's going to go down to -30, and it's going to be the coldest night for the last 3 years. So I'm happy to be virtually in Melbourne. Thank you very much for asking me to present at your meeting. And it's very nice to be on the same panel with my dear friend Sancha Randa. I don't think we've talked on the same program for a while. What I wanted to talk to you about today is one of the very cool programs at Princess Margaret. Closing the cancer care gap is a huge subject, and it may be due to many things, to attitudes, to resources, to access issues, lack of universal health coverage. And cancer is one of the most complex areas of healthcare. The complexity is due to the disease, but also to treatments, and also to rapid progress and many opportunities that we have to improve cancer care, as we've heard from other speakers. But to address that, we need to have the right people with the right set of skills. And a few years ago, my colleagues have initiated the Global Oncology Leadership Development Program. Danielle Roden is now Director of Global Cancer Program at Princess Margaret. She just had a baby 3 weeks ago, which is why I'm speaking. And Meredith Giuliani is a director of education, and two of them have developed this program really that is focused on our fellows. So as a background, Princess Margaret's a very large cancer center, and each year we have about 120 to 140 clinical fellows, so people who finish their specialty training and want to gain extra expertise visiting. In fact, there have been a large number of clinical fellows we had from Peter Mac, and some of them are on your faculty right now. And these people come to Princess Margaret to expand their skill sets. But often when they return to their own institution, they assume leadership positions, and yet we don't talk to them about leadership, or we didn't at all. And so in 2019, we launched this program just before the pandemic. And in 2020, it was started in person, as you see on the photograph here. But in 2020, it was converted to the virtual program. The idea was to provide additional skill sets to people that their fellowships do not provide. So why the Gold program? One of my favorite papers has been the Lancet Commission that was published more than 10 years ago now, which is called Health Professionals for a New Century. And that commission highlighted the need for expanded education and new competencies that are needed in 21st century. And they talked about inclusive learning that would lead to inclusive competencies. So the informative learning, that's what gives you expertise to be a specialist, to be a health professional. The formative learning means that you acquire social skills to be a professional, to work in the team. And then there are higher level skills that are transformative learning, which allows you to be a leader and a change agent. And considering the complexity of cancer, we think we need more change agents as we go along. So the curriculum in the Gold does not address expertise that is a focus of each individual fellowship, but rather it addresses the understanding of the ecosystem that oncology professionals work in. And then understanding the principles of global cancer control, cancer policy and health system, economics and financing of cancer care, opportunity for research innovation, and also some exposure to leadership training, both at local and global level. And we were hoping that this will be of interest in fellows, and indeed, each year we have about 30 to 40 fellows participating. They're from all over the world, and they're exposed to the issues that their traditional education does not address. And we have been very fortunate to attract experienced speakers who are experts in their fields, who are thought leaders, and who are also interested in helping us to shape the future cancer leaders. And I've just shown you the couple of pictures. Dr. Pramesh, who is medical director of Tata Cancer Center in India and is director of National Cancer Grid of India, very creative individual. Chris Booth, who is a health services researcher in Kingston, Ontario at Queen's, who has been launching the global health program, the global cancer program at Queen's. And my friend Felicia Knoll is an economist, cancer survivor, and a leader in global cancer control. Her key competence being economics and finance in cancer control. As part of the program, we also have a mentorship component, so that each fellow is paired with one faculty member that will meet with them several times during the year and can offer guidance and coaching discuss individual career opportunities, individual aspirations, or individual problems that they have. And most fellows do avail themselves of this opportunity. The program has been very successful, and we actually have demand for people joining virtually from outside Princess Margaret. And indeed, this year we've had few trainees from Tata, from India, joining us remotely. But our scientists were not very happy. They said, this is a very clinical program for clinical fellows. What about us? What about the PhD students and postdocs? So just this year, we are launching a BOLD program, which stands for Biosciences and Oncology Leadership Development, which will have similar but slightly adapted curriculum to talk to the research trainees and offer them some leadership insights and training that would hopefully launch their career so they can become change agents in their fields. And in addition, we have been engaged now for a few years in the program, Caro Aro Global Oncology Enrichment Program. And this program was started by, as an idea from the residents and specialty trainees in radiation oncology in the Canadian Association of Radiation Oncologists that collaborated with American Radiation Oncology Residents Organization. And they wanted us to develop the program, which we are running together with our US and international colleagues, really engaging radiation oncology residents in a global cancer curriculum. So I'm extremely proud of my younger colleagues initiating those programs and addressing to what I think is actually an urgent need, not only to create experts and right human resources for cancer, but also creating people who will be future leaders and change agents for cancer. So with that, I'm going to close and say how pleased I am again that you organized this wonderful afternoon in Toronto and morning in Melbourne to allow us to collaborate. I'm also extremely happy that we have now officially partner, although we've always considered Peter Mac as our sister organization. Thank you, Shelley.
Thank you very much indeed. Thank you so much. And I know that we all embrace, as you do, that leadership and change leadership will really empower our teams and really start to close the gap. We couldn't be more delighted that you joined us today, and I hope you're able to keep warm. I'm going to move us on now and introduce our next speaker. Janelle Loliger is an advanced practicing dietitian here at Peter Mac. She has 20 years of clinical, operational, and service development experience. She has a real passion for innovative quality improvement and uses a strategic approach to improve outcomes for people with cancer. She is a perfect example of one of those change leaders. Janelle is going to tell us today about scaling of the innovative award-winning Can Eat nutrition pathway for people with cancer. Thank you, Janelle.
Thank you so much, Shelley. Thank you for the invite and the opportunity to speak to you today. So I'm really pleased to be able to share our knowledge and some of our learnings in relation to our work on the Can Eat pathway, which ultimately aims to close gaps in cancer nutrition information and care. So firstly, I would like to specifically acknowledge Rebecca McIntosh, our project officer, our consumers, our 7 implementation sites, and the wider team that were involved in this work. So my focus today will be on our work on the Can Eat pathway, and this work forms one domain of the Victorian Cancer Malnutrition Collaborative, which is work led by our Peter Mac nutrition team and spans a broad range of work focused on improving care and addressing gaps in relation to cancer malnutrition. It's well recognised that nutrition forms a critical component of cancer care, and there's a raft of negative consequences to poor nutrition. However, variation and gaps continue to exist. So 32% of cancer patients are malnourished, and this includes approximately half of inpatients and about a third of outpatients. And more than half of these malnourished patients are not seen by a dietitian. Many multidisciplinary team members play a role in delivering nutrition care, so it's not just the dietitian. However, substantial barriers exist for health professionals in regards to knowledge and confidence in providing such care. And we've got consumers who are information hungry for evidence-based cancer nutrition information and care. So in response, in 2019, we developed the Can-Eat Pathway, which is a resource housed on the Peter Mac website that includes information, resources, and links about nutrition and cancer. In 2020, we commenced the next phase of this work, the I Can Eat project, and this aimed to further explore patient, carer, and health professional views regarding cancer nutrition care and information, to use the identified gaps in care and information to co-design new resources, and then conduct clinical utility testing of them across 7 health services. So today I'm really just going to give you a little taste of some of the work that we've been doing over the last 18 months, a little bit more. So this just gives you a schematic look at what we have done. So I really wanted to highlight our workshops. So we held 4 virtual workshops which utilised experience-based co-design, and this really was key to our project. So we had 20 participants in each of our workshops, half patients and carers, half health professionals, who worked in partnership to confirm nutrition information priority areas and to iteratively design and refine 46 new resources in a range of formats. So I'm just going to show you some of those now. We developed an A5 postcard and a general fact sheet, great visual prompts to direct patients, carers and health professionals to more detail on the Can-Eat Pathway web pages. And as agreed upon in the co-design workshops, all the resources were made to be visually appealing, in simple language, and focused on self-management and action-based dietary changes. We have 12 cancer type fact sheets for patients and carers, and an equivalent series for health professionals. A further 8 fact sheets focused on managing weight gain, myth busting, finding a dietitian, and a time series in the cancer path. So from preparing to treatment through to end of life care. Oops. Sorry. So we also had further toolkit resources that were also available to guide ongoing nutrition care and tips for good nutrition after cancer treatment. So we developed 4 animations. Sorry, my slides are a bit slow. A general one for patients and carers, one for health professionals, and a malnutrition risk screening animation. Consumers were embedded in all stages of our work. We had 2 incredible consumers on our steering committee. Over 100 consumers completed 2 rounds of surveys and 10 actively participated in our workshops. So just to show you some of the reflections from our consumers, including the value added by having consumers and clinicians work in true partnership, the success of the project driven by a diverse steering committee, and the ability of this work to set a new benchmark in patient information. So this study has really helped us to gain some incredible insights into barriers and enablers to nutrition care and information provision. The Can-Eat Pathway has been enhanced by 46 new co-designed resources and increased its uptake by 7-fold. Experience-based co-design has enabled a true collaborative approach. We demonstrated acceptability in a real-world setting where we tested our resources at 7 implementation sites, so 4 hospitals, 2 community health centres and a GP practice, including metro and regional sites. We identified areas for further work, so specifically around communication around nutrition care from one provider to another, and gaps in key transition points. And the CAN8 pathway really is your go-to one-stop shop for cancer nutrition information. So the CAN8 pathway is freely available on the Peter Mac website, and we're really proud to have won a 2001, what year is it? 2022 Partnering in Healthcare Victorian Public Healthcare Award, which really was recognition of a lot of people's work across the state. And the next steps are really extra enhancements to further identify and address both nutrition care and information gaps. Now, I'm going to show you one of the animations that we created, and this one's focused on health professionals, so we hope that you might be able to use these in your practice, and I hope you enjoy them.
Good nutrition is essential for all people with cancer throughout the entire cancer path. 3 out of 5 people with cancer will have a nutrition issue that is making it hard for them to eat well. At least 1 in 4 will develop malnutrition. Up to 3 of 5 will develop sarcopenia, and many may develop cachexia. Optimal nutrition is critical in preventing and treating these complex conditions. Good nutrition equals better health outcomes. Meeting nutrition needs due to increased energy and protein requirements is challenging. Cancer diagnosis, treatment and side effects may create further issues with eating and drinking. Optimal nutrition care should include risk stratification to ensure all patients are supported, with those at highest risk receiving care from a dietitian. Without adequate nutrition, patients can experience the need for artificial nutrition support, such as enteral or parenteral feeding, unintentional muscle and weight loss, which can lead to health issues such as malnutrition, sarcopenia and cachexia, as well as fatigue. Poor tolerance of cancer treatment and treatment interruptions, an admission to hospital and longer length of stay, and a longer recovery. The CAN8 pathway provides you with evidence-based nutrition information and practical tips. You can view the CAN8 pathway as a person with cancer or carer, or as a health professional. Everyone has a role to play. Optimal nutrition care requires a multidisciplinary team approach. As a dietitian, oncologist, GP, nurse, allied health professional, or other health professional working in a hospital or community-based setting, the CAN8 pathway can help you deliver optimal nutrition care to your patients and their carers. Have your patients ever said, "I feel so nauseous I can't eat," and you didn't have a resource to provide them? Do they ask about help to combat fatigue, to manage their weight loss or weight gain? Do you regularly discuss nutrition with your patients or direct them to further nutrition resources or advice? Patients with cancer and their carers are seeking credible information and view nutrition as very important, but have not always felt supported by health professionals. The CAN8 pathway provides resources and templates at your fingertips. Within the CAN8 pathway, you can watch a video, listen to an audio clip, read a fact sheet on a topic relevant to you, explore the toolkit for easy-to-use templates and resources. Boost your own knowledge and understanding of nutrition and cancer. Get patients back to the things they love by supporting them to eat well. Help them to build strength, boost energy, and lift mood. Ensure they make every mouthful count, as the CAN8 pathway serves up bite-sized nutrition information and support for all people with cancer and their carers, regardless of where they are on the cancer path. Everything is on the table.
Wasn't that fantastic? And such an incredibly important area, and one that has been overlooked for a very long time. So truly closing the gap there, Janelle. Thank you. It is now my huge pleasure to introduce our final speaker. I was going to say very old, but I shouldn't say that. Very long-standing friend and colleague and mentor, Professor Sancha Aranda AM. Professor Aranda is the former CEO of Cancer Council Australia, the past president for the Union for International Cancer Control, and the inaugural board chair of the Cancer City Challenge Foundation. She is rightly regarded as one of the world's preeminent experts in cancer control, with 40 years' experience as a clinician, researcher, educator, and health system administrator. She is now a professor of health services research, strategy and policy here at Peter Mac, and in the Department of Nursing at the University of Melbourne. We are really delighted that Sancha is here with us today. And Sancha is going to speak to us this morning on how we can use data to more accurately identify and tailor services, particularly for the more vulnerable members of our community. Thank you, Sancha.
Thank you, Shelley. And I too would like to begin by acknowledging the Wurundjeri Woi-wurrung people and to pay my respects to elders past, present and emerging. And I don't think you can talk about equity in any division of health without thinking about that. Shout out to Mary G over there in Canada. We have far too few opportunities to meet face to face these days, but many of my perspectives on cancer control in the global space are drawn from my time spent with Mary. And I think in thinking about measuring vulnerability, it used to be that I would go internationally and think about cancer in Australia as a really great situation. And then you see all the inequities and you see them as being between country inequities. And when you develop an international perspective, you come home and you look more deeply at what is happening. And that really has been an important perspective for me in the last decade, in particular in looking at inequalities in cancer outcomes. And it's that I really want to talk a little bit about today. And I'm going to do that at three levels, in really thinking about the population level where we have a paucity of data, at the middle level, or the system level, where we have issues around access to care that have already been identified today. And then at the patient interaction perspective, we were often blind to social determinants of health as we interact with people across the cancer control pathway. So what about at the population level? What do we know? And I'm not bringing a lot of perspective on this today, but really to say that if you are in the lowest socioeconomic group in Australia, you have a 37% higher chance of dying from your cancer than if you're in the highest group. And it's often thought that that is because people in the lower socioeconomic group have higher risk factors. And that is certainly true. Things like lung cancer incidence is higher and therefore the mortality is higher. But if you look here on this slide at the higher risk of dying from prostate, breast, melanoma of the skin and non-Hodgkin's lymphoma, each of those cancers has actually lower incidence in the lower socioeconomic groups and yet a higher mortality. And I think there's a real danger that we start to think about these sorts of mortality inequalities as somehow related to the individual and the person and not the wider ways in which services are provided. And it's often thought that it's because people present late. And so I had the pleasure when I was at Cancer Institute New South Wales, because the New South Wales Cancer Registry has collected summary stage for over 40 years, to be able to really look at, is it stage at diagnosis that's the problem? And so this is a 40-year analysis led by Hannah Tavonen, who was one of our postdocs. And we were in this analysis able to control for sex, age, remoteness, country of birth, cancer site, and summary stage. And what you see here is that as you go down the socioeconomic or into highest levels of socioeconomic disadvantage, that cancer outcomes are poorer, mortality, death, hazard of death is higher, but the gap is widening over those time periods. And so we're not getting better at this, we're actually getting worse. And at least part of that for me is because we don't really understand how the social determinants of health impact on the ways in which people interact with the cancer system. We're getting better, and Canada has a lot to teach us in this way. And if even any of you haven't interacted with the materials on the Institute for Clinical and Evaluative Sciences in Ontario, then I wish you could have a look at that. But we do at last have some action in government, and there is a multiple agency data implementation project now, which brings together all of the kinds of health, migrant education and social data, including income. Because when you look at that first slide that I showed, looking at socioeconomic disadvantage, that is only able to capture area level disadvantage. It's about your postcode. And as we all know, postcode is a very blunt instrument for looking at this. And so we're starting to see access happening. It's complex, it's long, it's expensive. But we do have 3 cancer registries in the country now that are starting to get this data in and being linked up with cancer registry data so that we can start to look in a more nuanced way at the influences on differences in cancer diagnosis and mortality. So that will be really important, but it is slow. So at the service level, what we fundamentally need to understand is that there's an inverse care law. This is a law that was developed by Dr. Tudor Hart in Scotland, who said that the more somebody needs healthcare, the less likely they are to get it. And we think that that's not so much a problem in a place like Australia, where we do have a universal health system, but I'm here to tell you today that around the world, this inverse care law is alive and well. And that we need to think about access to services as more than just their availability. And for any of you who haven't read this amazing paper by Jean-Fred Levesque and colleagues, it's really worth a read. I haven't got time to go into it, but it makes us think about access at the patient and community level, but also at the system level, with availability only being one aspect, and that this is a massively complex piece that I think came out a little bit in Andrea's talk, but is really something we need to understand much more. And so when you start to look at the inverse care law, you start to, if you assess for it, you see all sorts of really interesting things. This is a paper from this year. It is from Denmark, but it looked at whether or not having higher income or higher education influenced access to specialist palliative care, and of course it does. So if you have higher education, you're 1.69 times more likely to get access if you've got a higher income. But look what happens if you combine it, that you're well educated and you're wealthy, you're nearly twice as likely to get access to specialist palliative care. And if we look in the Australian context, we know that higher SES patients are 3 times more likely to ring the Cancer Council's helpline, and we have no idea why that might occur. Lower SES patients are less likely to have a follow-up to a positive bowel screening test. So we have a universal bowel screening test available, but if you're of a lower socioeconomic group, you are much less likely. If you are disabled, only 50% of people go through to having follow-up after a positive bowel screen. There's evidence of lower participation of low SES patients in trials, and social determinants of health are not even assessed in clinical trials or in anything else. So we have no idea how they influence things like adherence to treatments. But we do know that people who experience financial toxicity are less likely to get their scripts filled. And so there's also a paucity of evidence of what we need to do about this. This was a systematic review we undertook at Cancer Council Australia, where we only found 16 studies reporting on 19 interventions that actually attempt to close these care gaps, and all of them were in screening. There was almost nothing that was effective in anywhere outside of screening. So we're not doing the research. And when you look at nurses as the frontline health professionals in much of this, they have very low confidence to ask about social determinants of health. And the barriers that they identify are things like time, a perception that the patient won't be comfortable if you ask them about these kinds of things, such as transport, discrimination, utilities. I think Andrea's touched on that a lot, that they feel discomfort and they don't know how to go about doing that. So when you get to the patient level, we need to start to begin to address this inverse care law. And I'm delighted today to just talk briefly about some work that Professor Maya Krishnasamy from Peter Mac is leading on the development and testing of a complexity checklist. This is a piece of work that has been going for many years now, that began with a review of the published literature and a national consultation with specialist nurses about what were the things in their practice that they thought were adding to the complexity of patients that were likely to impact on their cancer outcomes. And this has resulted in a checklist that has good face and content validity and is undergoing clinical utility testing at the moment at Peter Mac using prospective mixed methods design in 4 cancer services. And this is the checklist. And you'll see that in the end, while we started this work looking at the idea of complexity, what ultimately happened that came out of it was really an index that is the social determinants of health: social support, living arrangements, distance and treatment, financial toxicity, being a First Nations Australian, a migrant, someone with caregivers that perhaps not coping so well, and then obviously the disease and health related things. And what's interesting in this study is that this is some of the early qualitative data, is we're starting, and I'll let you read the quotes, but we're starting to see that this checklist is addressing some of the barriers that nurses have in addressing these issues in practice. It's giving them a systematised way to think about assessing social determinants of health that's increasing their comfort. And importantly, we have early indications that patients are comfortable with being asked these questions and that they see them as being important, and that they recognise that the clinicians don't know their situation unless the questions are asked. You can't take account of these things in practice. And so in summary, I think that one of the biggest challenges that we face is cumulative disadvantage. So we often think about these things as one-offs, so they're either rural or they're poor or they have low health literacy, but actually there's a situation where you get cumulative disadvantage. This comes from a concept of cumulative advantage. We saw before that if you're well educated and you have good income, you begin to get cumulative benefits. But the cumulative deficits is what we really need to understand and how we overcome them. It's critical to include these social determinants of health measures in population service and patient care levels so that we can really begin to see, well, where will be the things that we need to address. The checklist might be one way that we can do this, if we can embed this kind of information in the EPIC system so that all clinicians have access to it. And to build these as what I'm calling accountability metrics. How do we ask health services and health systems to be accountable for addressing the social determinants of health and their impacts, and giving us all the responsibility for doing that? Thanks so much.
Thank you very much indeed, Sancha. And Sancha has really put the challenge out there, hasn't she? As ever, another incredible international leader of change. And I think we at Peter Mac, but across the world, need to take on that challenge and use it to address the care gap on World Cancer Day, which we celebrate tomorrow. Now, thank you all for being so patient and staying with us. As you will realise, we were a bit ambitious in packing in the agenda today, so we don't have time, I'm afraid, for questions. If you would like to ask questions of any of our speakers, please do email them into our communications team, and we will get some answers out, perhaps all together, so that that's useful for people. Can I conclude by saying a huge thank you to everyone joining us across the world. Thank you for our international speakers joining us at all times of the day and night. I want to say a very warm thank you to Nicole Brady, who has joined us today from the Department of Health. It always really enriches us as a whole system that some of our leaders in the department come to join us for these symposiums. And we're very lucky that Nicole Brady is with us all today. So Nicole, thank you for being with us. We're delighted. And can I also say thank you to Idan? I can't see where Idan is. There he is. Idan Goldenberger is the Executive Director for the Australian Friends of Sheba Medical Centre, and Idan is an absolute force for good and bringing us all together across the world in a tireless and passionate way. So thank you again for Idan for being here with us. Thank you to all the amazing speakers. You really have enriched us with your thinking and reflections, both here in Petermac, but also our international speakers. So as we go forward, let's not forget that it is so important to close the gap. And let's make 2023 a year that materially brings that gap a bit smaller. Thank you so much for joining us. Have a wonderful day and a wonderful weekend. Thank you.
Thank you.